And it's just a great honor for me today to be podcast interviewing Dr. Jennifer Hirsch Doobrow, a Board Certified Periodontist, is the owner and CEO of Periodontal Implant Associates located in Cullman, Alabama. She earned her DMD at the Medical University of South Carolina in 2007 and received her certification in periodontics from the University of Alabama at Birmingham in 2010. She serves as a faculty member for the Pikos Institute, who I think was podcast number 180, 187 for us, was the general chair for 2017 Gulf Coast Dental Conference and is the 2017-2018 chair of the Leadership Council for the University of Alabama School of Dentistry. Dr. Doobrow is on the Executive Council and serves as the Corporate Advisory Chair for the Southern Academy of Periodontology and sits on several committees for the American Academy of Periodontology. She holds past president positions in the Alabama Society of Periodontists and the Wilson Chenault Dental Study Club. In 2012, Dr. Doobrow was recognized as one of the University of Georgia's prestigious 40 and under. Most recently, she was selected as one of the top 10 young educators in America for 2017 by the Seattle Study Club. Wow. Was inducted as a fellow of the International College of Dentists as well as fellow of the American College of Dentists. She was also awarded the UAB School of Dentistry Outstanding Young Alumnus Award and was featured on Lifetime Network's The Balancing Act. She has published articles in Compendium, Implant Dentistry, DentistryIQ, Surgical Restorative Research, and Perio-Implant Advisory, and lectures extensively throughout the United States on dental implants and periodontal regenerative therapies. Dr. Doobrow hosts an annual dental symposium in Cullman, Alabama with 1,000 attendees in 2016, and you can find her on a Lifetime channel interview on the Balancing Act. We'll put the link in the notes to that. But man, you must not sleep. Are you one of those sleep apnea people who only sleeps 2 hours a night?
But the rest is for the weary.
My God, I got to tell you, as a periodontist, I graduated in 30 years ago in 1987, and I looked at all the 9 specialties, and I think periodontists, that specialty changed more than all the other ones. I mean, I look at what changed in like pediatric dentistry and orthodontics, and it's just kind of minor, just minor stuff, incremental improvements over the years. But man, when I got to school, periodontal surgery was all about periodontal surgery. And then,
right.
Then it switched to, why would you do periodontal surgery? Just pull that thing and treat it with titanium. And now that the literature is saying that at 60 months, 20% of implants have periimplantitis, now I see the pendulum coming back. And now I see
Absolutely.
a lot of dentists saying, that periodontal surgery looks better than before. Do you see it that way, the pendulum swinging left to right and coming back?
Absolutely. I think it's a dynamic process. It's very fluid. It's really interesting, Howard. My dad was actually a practicing periodontist as well, and right around the same time that you guys came out, and maybe we'll get into that at some point. But, why do we call it practicing? It's an evolving profession. It's an evolving environment that we're in, very dynamic, and it's exciting. That's why I'm so passionate about what we do every day, because we're always learning new technology. We're always learning new philosophies. And it's what's the best way that we can treat our patients at this moment in time.
Well, I have another historical question I want to ask you. In 1900, only 1% of the GDP was healthcare. And by 2000, it was 14%. And in 1900, it was 1%, no specialties. By 2000, it was 14% and 58 specialties. Now at 2017, it's 17%. And now I see these dentists come out of school and they want to master implants and ortho and pediatric dentistry and endo. And it's like, are we going back to 1900 where this one doctor does everything? Or, I mean, you know what I mean? It's kind of like
Absolutely.
the super. And then when young kids say to me, I want to learn sleep apnea, being an old man, the first thing I ask, okay, well, if you're going to learn sleep apnea, what are you going to give up? Because it would be a full-time job for years just to learn sleep apnea. And they go, oh, no, I'm not going to give up everything. I want to do ortho, sleep apnea. I want to learn how to place implants, bone grafts, sinus. It's like, can you really be the super dentist from 1900 with no special?
I think it's a phenomenal question, Howard. Can I personally? No. That is why I specifically picked a specialty to go into. There may be others that can have a multitude of techniques and technology that they use and they feel comfortable with. The best advice that I can give those that are starting to try to figure out their future and the direction they want to go is find out what you're passionate about. Do your due diligence, look at the science, look at where the direction we're going with that specific technology that you want to use, and be darn good at what you do. Because the best thing that we can do as a profession is be the experts and leading experts in our field.
I got this question. I lectured yesterday. Ryan and I were in Toronto, and a young dentist who was 20, I think she was 27. She said, she goes, this implant company has a 98.5% success rate, but then it had all these pros and cons, and the other one had a 97.9. She said, would you go with the 98 point? You know, what do you say to these kids when they see these full page ads and webs and Facebook ads and all this stuff, and they're saying that their implant has a 98.5% success rate?
Well, like I said, what I was mentioning before is do your due diligence, understand the science of that specific product that you're using, the technology behind it, what went into it, look at histology, make relationships, long-lasting relationships with those companies. Because I can tell you, being involved, and Howard, you may be able to attest to this and speak to this as well. Being involved with dentistry my whole life. My dad was a periodontist, a practicing periodontist for what would have been 40 plus years. My mom sells dental supplies, so I've got a unique background, and that's for sure. I mean, you asked me about sleeping. We sleep, eat, and breathe dentistry in our family, and always have. And the best thing that I can tell those individuals coming out is know who you're working with. Because you and I know this. What happens? You've got somebody that's got the latest, greatest product, and the next thing you know, they're down the street working for another company having the latest, greatest product. So you need to know who you're working with and what you're working with before you stick your hands into that environment, that technology, that science.
You know, last year at the Greater New York meeting, Amazon had a booth there. And when we started Dentaltown in '98, a lot of people said, well, you should sell supplies. And I said, well, we're trying to form a community so that no dentist has to practice solo again. And right now, before the internet in Dentaltown, your only link to the community was your reps that would come by and see you. And I said, they don't want to cut off that rep. And if you start buying everything through Amazon, who would be? I mean, I asked my rep questions like, well, who uses this endo file? And she just starts rattling off the names. And if she says like, well, Brad Gettleman, your favorite endodontist, uses this, well, that means a hell of a lot to me.
Absolutely.
Not that I can buy 3 and get 1 free.
Yeah, no, you're exactly right. And, you know, talk to your colleagues. This is what I would tell rising dentists and individuals coming out of school. Talk to your colleagues, hear who they speak with, learn about how their experience have been. I always say there's no panacea. You know, what we do, there's no make or model that's going to fit perfectly for one person that's going to fit for the other. So get opinions, get advice. The best thing that I could have done along my journey is form these relationships, these partnerships, and quite frankly, the mentorships that I've gained. You mentioned Dr. Pikos. If I hadn't been part of that experience and gotten to know an individual that's been practicing for that long, you know, who knows where I would have been. So find those partnerships and mentorships early on, for sure.
Yeah, and he's been practicing a long time. He's a lot older than me. Just a lot older. In fact, I think I'm younger than his children. I want to separate this into 2 things. Well, first of all, let's just realize this. I always tell my guests, shoot me an email, howard@dentaltown.com. Tell me your name and how old you are. I just kind of, because, you know, you don't know who's listening to stuff on iTunes and Facebook and all that stuff. And what's bizarre is about 5% are applying to dental school. A quarter of them are in dental school, but almost every other one of them is under 30. I only get like 1 email a month that says, dude, I'm as old as you. I'm a grandpa. Love your show, whatever. But one of the things that really troubles them is they'll have a patient with periodontal disease and you know, they can't, you know, how do you wrap your head around periodontal surgery versus the hell with it, just extract it and do implants? And then they're reading on these older cases on Dentaltown that were done 10, 15, 20 years ago that implants get periodontal disease. Hell, 20% have peri-implantitis at 5 years out. So how is she supposed to go with the diagnosing and treatment planning of when to do old-fashioned ancient periodontal surgery versus space-age titanium?
Absolutely, great question. And you know, what's so fun about going out and having the opportunity to lecture and meet different people is you get these wonderful questions, and depending on demographics, it may be answered differently, depending on the locations that we are. You know, I'm in Birmingham, Alabama, and my practice is in rural Alabama, so how I address that question may be different than if I was some large urban city. So that's the first thing I can say. But what we have to remember, Howard, and as a periodontist, I know you know this, we eat, sleep, eat, and breathe this, that over half of the American U.S. population over the age of 30 has some form of periodontal disease. And what we forget is this, that periodontal disease comes in many shapes, forms, and sizes, because you're looking at everything from an inflammatory disease that can be reversible like gingivitis to severe periodontal disease, right? But what we also forget is when we look at an individual, what else is periodontal disease? Periodontal recession, there's bone loss there, which has instituted gum loss. So we have to look at the big picture here. And again, what I was saying about technology and procedures as well as instrumentation, there is no panacea. You know, I don't look at one mouth and say this is an implant case. The first thing I can tell you is all of our patients we consider our friends and not as patients. That's a huge piece of advice that I can give individuals. Don't think that when somebody walks in, when we leave dental school, it's ingrained in us that we have to conform to these, we need to reach this curriculum and these statistics, right? We need to, what's the word for it, Howard?
Requirements, curriculum.
Requirements, right? So you're now practicing on individuals each and every day that are coming to you because they trust you. They're not a requirement fill anymore. So to all that to be said is you need to treat them like a person. Howard, if you came into my office, I'd want to treat you just like I would treat if you were a family member, my brother, cousin, whoever. And that's what you have to think about when you see a patient. Don't look at the mouth and look at 32 white things in a black hole, right? Look at the patient, look at their family history, look at their medical history, look at what they do, look at their educational background. Because again, another way to look at it, I'm not going to talk to a truck driver that walks into my office the same way I'm going to talk to a hairdresser. I'm not going to talk to somebody that's got a PhD in astronautical engineering that I am going to talk to somebody that's a farmer. So we need to look at those individuals as individuals and not as patients, and not as a requirement that we have to fill, and not as a dollar sign that we need to recoup.
Well said. I love that. Yeah, Alabama has a lot of astrophysicists. That they made the solid rocket boosters. What, in Huntsville?
Absolutely, Huntsville. Yep. Which is, so where I'm located, where I live is in Birmingham. My practice is an hour north of where I live. So I actually commute an hour each way every day. And then Nassau, Huntsville is about an hour north of that. So where we are, we're kind of centrally located in different areas. And you know, it's amazing. I mean, it's very diverse with what's the best way to say, maybe dental IQ in our state.
Yeah.
You know, and so you have to understand how to relate to everybody.
And I lectured one time in Alabama on the Gulf Coast in a casino on the Gulf Coast. That was so beautiful. That was gorgeous. So should I assume that since you're in Alabama, you use BioHorizons since they are out of, aren't they out of? They're out of Alabama. Where are they? Yep,
they're out of Birmingham. And you know, going back to your question, Howard, about you know, the companies that you use and the products that you use, and going back to relationships, you know, for me, it is very important to be able to support local groups if I have the ability to do that. And there's a lot to be said because it's a partnership. It's a win-win. If I need something, my rep, my territory manager can just bring it up to me versus, as you mentioned, a mail order. You can't get that in 25, 30 minutes.
So was I right? You seriously use BioHorizons?
Yes, sir, I do.
Oh, that is so cool. That is so cool. I was born in a small town, Wichita, Kansas, and now I'm in Ahwatukee, which is really a small town of 85,000, separated from Phoenix by a big mountain preserve and an Indian reservation interstate. And I always told my kids, if you have a chance, if you need a lazy boy, buy it in Ahwatukee. Don't go over to Tempe and Phoenix and Glendale. I do all my shopping in the backyard. So you do use BioHorizons. That is an amazingly good deal. So what is so again, I don't know what to talk to you about, periodontal disease or implants, but let's start with periodontal disease. What's got you most passionate today about treating periodontal disease?
I love that question. Thank you. I can tell you, I don't have my scrubs on right now, but our scrubs say for our team, it says changing lives one mouth at a time. And I like to pause when I say that because to me, changing lives as one mouth at a time, that's what we're doing each and every day, or we should be. So I was mentioning something about my background when we first started. My dad, Howard, was a periodontist, and the intervening summer between my first and second year, my 3-year residency, he passed away suddenly.
Oh, I'm sorry.
And he was, you mentioned your age, he was 53 years old.
Oh, my.
Yep. So what I can tell you was my experiences at the University of Alabama, where I did my periodontal residency, if it wasn't for my faculty there and the mentorship that I've gained through this really horrific experience, but really to turn it around in the best way that you can possible, to use that as a motivator and to help others. It had such a huge impact in how I practice today. And all to be said that taught me about what is the foundation about what we do. You know, whether it's an implant or a periodontal disease, you know, my whole thing, especially being in Alabama, you know, you hear a lot of people say, bless her heart. Well, it's true, because we really believe in our practice. We tell our patients, if God gave us our teeth for a reason, we want to try to help you save them. If we have the ability to save your teeth, or at least give them that option, don't you think that patient's going to trust you? And they're going to send their mother, their brother, their cousin to you because they know you have at least given them a chance. And then if they need an implant down the road, then you've already built that trust, that relationship between the two of you. And there's no stronger bond between a doctor and a patient, or a doctor, a patient, and your team member, to be able to cultivate that trust, especially in a small town of where we are. It's all about the word of mouth.
So now the most important question, did your dad like the bear?
So it's funny, my dad is actually from upstate New York. So he became, I guess, by proxy, an Alabama fan. So my dad is from upstate New York, but or actually the New York area, New York, New Jersey. But when you come to Alabama, it becomes ingrained in you. But today's actually a pretty dark day in our household because I cheered at the University of Georgia. So yesterday was not a promising day for us.
Man, I love the bear. He was so fun to watch. My gosh,
Yep.
yeah, he was a legend. So I want to talk about BioHorizons just for a second, in the fact that when I look at the well, first of all, you just need to have a high quality implant company that's been in existence 10 or 20 years. The biggest disasters I see is these, you know, there's over 750 different dental implant systems in the world today. There's over 75 just in the country of Italy. And these people, they buy these implants and they do these big cases. Then 5 or 10 years later, that company's gone. And then they need a part or a screw or a fixture,
Right.
and the company's gone. So you got to have staying power. And then the other thing I've seen is that, you know, there's just a handful of companies where if you did get sued and you're using an implant that has no research or no R&D or anything like that, that can look very bad. But whenever I meet anyone who made it past placing 100 implants, they always have a human relationship in the field. And that human relationship is so important for getting over the tipping point. Like maybe your rep will say, well, you know what, that's a great question. Let's go to lunch with Dr. So-and-so. And they're
Right.
working the grapevine. I mean, you know, the implant company I use is basically an alcoholic drinking club. At least once a month, 5, 6, 7 of us dentists are at the bar, and it's so fun to go after work and have
Right.
drinks with all and talk about it all night long. So I think the human capital in the field is so important to do. So you talk about specifically regenerative periodontal therapy. Talk about that.
Yeah, so as you were asking before about, you know, treating a periodontal disease, I mean, as a periodontist, what do I want to do? I want to save teeth if it's possible. And again, I really mean it, that trust that you build with your patients. If you know, what you have to remember, what we all have to remember is you don't ever want to overpromise to your patients because you don't want to be the one to underdeliver. And I think you were spot on, Howard, earlier when you asked about, can we all do it all? You know, so number one is you don't want to overpromise, so you don't want to underdeliver. And so with that being said, when I do regenerative medicine, I mean, we're talking about regenerating bone, cementin, and PDL around teeth that have 14 and 15 millimeter pockets. And 7-8 years later, I clinically have results where we're able to see these patients still have the teeth in their mouth. And not only are there still teeth in their mouth, it has truly changed their lives. Because what I think we all tend to forget, Howard, is just like if, God forbid, a patient of yours, a friend of yours, a family member has to lose a limb, a lot of these times, these patients feel that if they have to lose a tooth out of their mouth that they've had for 30, 40, 50 years, it's just as significant and impactful in the life as just as losing an arm or a leg. And, you know, going back to, you know, I can't tell you that we can save every 14 and 15 millimeter pocket around a tooth, that we can keep that tooth. But what I can tell you is we're darn well going to try if we have the ability. But going back to what we were saying, knowing those individuals in your office, you have to understand there's so many patient-related factors. So what we need to understand is it's all about the host response, and host response goes back to a lot of things. Is the patient healthy? If they're not healthy, do they have comorbidities? Are they a smoker? Do they use alcohol in excess? There's so many factors that you're going to do. If they tell you they're going to brush, are they going to brush with the wrong side of the toothbrush, right? One thing I've learned is don't ever ask a patient a yes or no question, because what's always going to be the answer? Yes, if you're trying to look for a positive response. You need to ask a patient, how often do you brush? How often do you floss? So all to be said that we need to understand that there's limiting factors, but we need to be aware that they all are different from one patient to the next. And even so, Howard, with that being said, one side of the mouth I may treat differently than another side. One quadrant I'm going to be treating different than another quadrant.
These kids are coming out of school with a lot of student loans. And, a lot of them are coming out with $350,000 student loans. So I want to ask you a big dollar question. A lot of times they start getting, if they're interested in perio, they start thinking of LANAP. But LANAP is a $135,000 commitment. What are your thoughts about LANAP, and is it worth the $135,000 commitment?
Well, I can't speak specifically to LANAP, Howard. I don't personally use that technology in my practice at the moment. But what I can tell you are there's certain additions to my practice that I feel are game changers that have a pending cost on them. For instance, my 3D cone beam technology. That's something I couldn't live or practice without. So specifically about LANAP, like I said, I can't speak to that, but there's going to be a cost that you have to really weigh, just like your patients do with the treatment that you're going to recommend to them. There's got to be a cost-benefit analysis that you need to do throughout this entire process.
But you are all that in a bag of chips, and you're doing all that in a bag of chips without LANAP, so that speaks volumes to me. So you're doing it all. God dang, the Seattle Study Club, that's the hardest speaking gig on earth, and they gave you what was the top 10 young educators in America by the Seattle Study Club. So if you got that, and you don't have, and you did it all without a laser, was that presumptuous? Maybe do you use another laser?
Not currently, I don't. But
okay,
but
so
again,
you're able to do it all without lasers. Can I ask you? I want to ask you two more questions, just because they got to watch pennies. If you come out of school $350,000 in student loans, there's some expensive courses. One is the pinhole technique. One is the gumdrop technique. Are these great courses in your opinion, or have you taken those courses? Or
so I have not taken those two specific courses, I can say that. But what I can tell you is there's so much value in quality CE. Whatever it is, whatever excites you, whatever you're passionate about, be sure to follow through with that, because none of us are doing anything that we're doing today that we were yesterday, and the same thing will change and evolve. As you were asking about the pendulum, it'll swing again. What do they say? When you go to a CE course, the information becomes, it's transient, it becomes cyclical, where 2 to 3 years from now, that same speaker will maybe be speaking on a totally different topic. You know that. I know you attend so many of these courses. You got to know what your value. What are you trying to get out of this course?
You know what the best periodontal and implant lecture course I ever took in my life?
What's that?
The one that you're going to submit next month for dentaltown.com for the online. I want you to put up a course so bad. Seriously, I think that'd be so amazing. Here's another periodontal question. A lot of patients ask, do you believe this true or false? Should you use a manual brush or an electric toothbrush? Some people would say, Jennifer, if you're going to cut this table in half, would you use a handsaw or a table saw?
Right.
Is that a fair analogy, or is that not really a fair analogy? And what do you recommend? Manual brush or an automatic?
Yeah, absolutely. No, in our practice, we really discuss in length with our patients using electric toothbrushes. We actually have something called a test drive, which gives them the top of the toothbrush. We actually let them hold the toothbrush. We show them how to use it so they can see the difference between the manual and the electric in their own hands. And especially with those, again, it's about a dental IQ. It's about manual dexterity. There's so many factors that play a part in that. So why not take part of that out of the equation and let an instrumentation that has so much science behind it do the work? And there's so many products with, you were asking about companies. There are tons of different companies out there that if you're recommending a specific toothbrush or toothpaste or whatever it is, just know the science. Do your own due diligence, because you want to be recommending something that you would potentially be using in your hands as well.
Well, speaking of that, you just walked into the next question. there's a lot of research that says that you don't need any toothpaste, that dry brushing is just as effective as moving plaque. And
Right.
that, do you think there's science for toothpaste, or do you think dry brushing is just as effective for removing a plaque?
Well, being a periodontist, you probably know this. You just opened up Pandora's box with that question, right? Because, depending on who you speak to, and depending on the literature, some say that even using a toothpaste, a dentifrice can lead to abfraction lesions, right? So, in our office, I can tell you that we do recommend using a dentifrice. We recommend using an ADA approved. How many products you're talking about? You asked about Amazon earlier. How many products out there now? I mean, I've heard some that are made out of charcoal, and I can't even go in that direction because I don't even know how to speak about what products are out there anymore. In our office, we go with the science-based products that have, the histology and everything else behind it.
I want to ask you the most controversial question, the most controversial podcast I ever did in my life. You talk about Emdogain, LPRF. Well, let's go to PRF. I did a podcast interview with Carl Misch on his deathbed. My show's an hour because all my homies say they have an hour commute. Like you have an hour commute.
Right.
That's our typical podcast audience. And they can't listen to politics anymore. They're so sick of everything in politics and Putin and North Korea and all that stuff. But anyway, but Carl went on for 2.5 hours, and I sure as hell wasn't going to stop or interrupt him. But he said that was voodoo. He said there's no research for that. He said these people drawing blood and spinning blood, and my God, that set off a firestorm on Dental Town. What is your thoughts on PRF?
So it's really interesting you ask that because, as I've been talking about, you need to know the evidence, you need to know the science.
And by the way, Carl Misch was involved with BioHorizons in the beginning.
Yep, absolutely. And it's very fascinating. You just mentioned Dr. Misch because I really had an amazing opportunity and good fortune. I was able to attend one of his very last lectures. It was and actually in his honor, going back to Dr. Pikos, he did an honorarium in his honor. He wanted to have him present in the moment before anything, he unfortunately wasn't going to be with us any longer. And he was supposed to go on for 30 minutes, Howard. I think he also went on for 2.5 hours. And he was in his element. And to experience Carl Misch at that level and knowing what he was experiencing within his own body, I mean, I get the chills just thinking about what that was and to be present there for that. Anyway, you kind of got me off of a little tangent there. But I will tell you from a clinical standpoint, what leukocyte, and I use LPRF, I use leukocyte platelet-rich fibrin in our practice. What I can tell you from a clinical standpoint, the patients that are coming back, the individuals in our practice, when we are doing very large cases, full mouth surgeries, these patients are coming back and they are not having to use any adjunct for pain, for medicaments to treat any pain. I shouldn't say any, but it's few and far between in comparison to what we used to do prior to using this type of technology. From a marketing standpoint, in the sense of telling a patient that you are going to use their own blood, spin down their own blood and show them exactly what you're going to do, it blows them away. Because what do people now want nowadays? They want an all-natural, for the most part, at least in our area, they want an all-natural alternative. They don't want to have all these medicines thrown down their throat. They don't want to be on steroids. They don't want this. They don't want that. So if you're going to give a patient the opportunity to use what they have from their own body, it is such an amazing connection that you have with these patients. Like, wait, you're going to use my blood to do what? So from your question, what I can tell you from a clinical standpoint, Howard, the response, the reduction of pain and discomfort, and quite frankly, swelling as well, has been remarkable. I mean, between the use of, you mentioned Emdogain earlier, enamel matrix derivative proteins, and LPRF in my practice, those and the cone beam CTs, 3D technology, those are 3 major game changers in our practice so far.
Well, so that means you're a periodontist and a vampire.
Exactly. Just don't tell anybody.
Well, you know the difference between my age and your age? You know what the hot, you're talking about a CBCT. You know what the hot update was with a year and a half after I got out of school? You could update your pano so that it had an L on one side and an R on the other. And I thought that was the coolest thing in the world because every time you showed a pano to someone, they'd always say, "Is that my right side?" And that was just so cool.
Isn't it exciting though? Don't you love being in dentistry because of just what you said? It is always evolving, and you know what? We as leading experts in this dental field need to stay on top of it. I mean, I think it's our duty to do that, because why else do we do what we do?
Well, you might have been talking over a lot of kids' teeth. You were talking about LPRF. They only heard about LP. They only heard about platelet-rich fibrin, PRF. I think this might have been the first time a lot of them heard L, and a lot of them probably never heard of Emdogain again. So can you go back and say what's the difference between PRF and L for leukocyte PRF, and then explain again Emdogain, which is made by Straumann, right?
Yes, it is. Yep. So what LPRF, leukocyte platelet-rich fibrin, what that's going to be is when you're actually going to take a patient's blood, so oftentimes out of the antecubital fossa, sometimes in the hand, wherever you can get the best blood draw, and you're actually going to spin down that patient's own blood in a multitude of tubes. And what you're going to be able to get out of that, I wish I had a drawing, even though my schematics are not very good.
You can put it on your online CE course.
Absolutely. I love it. We'll do some videos for you. How's that sound?
I would love it.
But basically what you're able to do is you're able to use their blood, and if you look at it in a tube, it separates out into a liquid, into a fibrin, a membrane. And the membrane you can literally use as a membrane. You can use as a plug from an extraction site or an extraction site. You can also use it underneath on the palatal, lingual, buccal aspect of a flap. And basically what it is it's upregulating growth factors is the best way to describe it, right? And so the difference between that and something like an enamel matrix derivative protein, that is now going to be from a porcine derivative, so not from the own host, okay? And that's actually, like you said, that's manufactured from Straumann. It comes in a tube. And basically what that is, that right now is one of the top products out there that has the most science and literature to prove periodontal regeneration. So regenerating the periodontium, the bone, the cementum, and the PDL. So I use those, Howard, in cases of deep periodontal pockets. Whereas the PRF, LPRF, I'm using those in conjunction with the Emdogain. I don't know if that does that help to clarify some stuff?
Yeah, that's very good. It seems like in my 30 years, women are just at least 2/3 to 3/4 of my perio program. I mean, I can get the average mom in every 3 to 6 months, but her husband, every year or every other year. It seems like when I talk about we could do this or we could try to do a new implant, it seems like women in where I live would go to the end of the earth to keep their natural tooth more than a man. Do you think, is that a fair assessment of women versus men in wanting to keep their body part?
Yeah, I mean, if you're going to look at it globally, potentially yes, but I think it's up to us, really, Howard, to educate those patients, male, female, young, old. It really is. In the global perspective, to answer that, yes. But that's kind of my mantra, to try to change that mentality, and it shouldn't matter, what your gender is. Now, is that going to still be the case? Possibly, because I guess you're a man, you probably can answer it better. Would you rather just do something quick, take out a tooth and try to put an implant in? But to answer that in this perspective, I have to explain the difference between a tooth and an implant and make sure they understand that somebody's got periodontal disease. If you're losing a tooth due to periodontal disease, you can potentially have the same type effect on an implant as well.
Back to the difference between men and women. When a woman has a gummy smile, it really, really bothers her. A lot of the men that have a gummy smile, I don't even think they know they have a gummy smile. What do you do for a really gummy smile?
Yeah, so the specific techniques you're referring to?
Yeah.
Okay, very good. Well, I love this as well, because this brings me to how important interdisciplinary approach to dentistry is, right? So I would never just look at you and say, well, you've got a gummy smile, Howard, let's just remove this tissue. We're going to remove some of your gums, and I'm going to give you your smile that you think you want, okay? So what's very important with that process is, and I actually have a couple of these different cases going on currently, I work very, very closely with my referring doctors. And to approach these, we're going to make sure that there's going to be a wax up, that I'm going to have a stent from that specific referring doctor based off of if they're planning on having restorations or not. And then depending on what my potential diagnosis is for the cause of the gummy smile, right? If it's ultrapassive eruption, if it's vertical maxillary excess, it's all going to depend on how I treat that case. So sometimes in a crown lengthening procedure, for those individuals that are just coming out and trying to understand the difference in how we do procedures, you need to look at what's the reason why this has occurred. Are you going to just be removing excess gingival display? Are you just removing excess tissue? Or actually, are you going to have to recontour the underlying bone in order to get the potential end point that we're trying to reach? And I think, Howard, it's really important to understand this. I think we all need to look at dentistry maybe a little bit differently than we do. I think a lot of people go into dentistry and again, they think, look at these 32 white things in a black hole, right?
Right.
But instead, why don't we look at it with the end in mind? You know, if you're placing an implant or you're doing a full arch rehab, we need to be, especially as a periodontist, I need to be prosthetically driven as far as what my end result and my endpoint is going to be. And it's the same thing with a crown lengthening case. It's even the same thing if I'm doing periodontal regeneration. I need to know what the endpoint is. Is occlusion the factor here? Is that why? And if I treat, for instance, if I go and I treat a full mouth of 4 quadrants of periodontal surgery or full mouth of periodontal recession, if occlusion is a factor here and I don't treat work with the referring doctor and the patient to understand this, what have I achieved? That patient's going to probably be right back in my chair 2 to 3 years.
This question, I don't want to throw any of my homies under a bridge. I love my homies. And when I see my homies disagree, I always tell the young kids that I'm 55. Every major Supreme Court decision I've ever seen in my life is 5-4. They both read the same Constitution. They both went to the same law school, and one saw red and one saw yellow, you know. But when I look at my friends, and just the ones that have drinking problems that I hang out with at bars, it seems like half of them never have done a crown lengthening procedure or referred it to a periodontist, and the other half can't live without it. I mean, that's real America. Real world America is half these dentists, they just don't do that. So why do you think half do crown lengthening and refer to periodontists have crown lengthening? I mean, what percent of the dentists do you think in America in the last year did not do one crown lengthening, refer one crown lengthening? What percent did refer? Just, I want to ask you that first. What do you think the macroeconomics is in the United States on crown lengthening?
Oh, it's got to be low, right? But it's the same thing for referring for periodontal recession. I mean, how many times do you think that we weight watch in a, and I'm just going to say it, and maybe a general dentist practice can tell you that I see this with different practices, especially traveling around the United States and speaking, that a periodontal recession lesion has been they waited and watched, and now instead of being a class 1, it may be a Miller classification 3, right? You're past the mucogingival junction. So it's the same thing potentially with something like a crown lengthening. A lot of times, it's not as, maybe it's not identified as disease, right? Because in the case of crown lengthening, are we doing it for aesthetics, right? Or is it a functional purpose? I would tell you from a functional crown lengthening standpoint, I would think that the number's much higher because the referring doctor needs that surgeon to possibly reduce the periodontium, reduce the bony structure underneath in order to place a restoration on it. But for an aesthetic reason, unless the patient brings that to their attention, I think very rarely are those patients going to be referred.
She's a little girl. She's 25. She just got out of dental kindergarten, and she goes into practice with her mom, who's a dentist, and her mom's never done a crown lengthening procedure in life. So you got her ear right now. Why should someone do crown lengthening? And she's never going to get exposed to it because her mom's been doing this for 30 years, and we'll remind her every day that she's been doing this for 30 years. So what would you tell this young kid that just walked out of dental school? Why would someone do crown lengthening, and why do over half the dentists never do it?
Right. No, I think it's a great question. I think it goes back, Howard, to understanding the needs of your patients, right? To understanding the desires and the wants and the needs of our patients. So if crown lengthening and aesthetic crown lengthening is really more than anything, and I guess if you look at it from one perspective, could be considered an elective procedure, right? And unless a patient finds it and that this is a strong desire that they have, oftentimes if you were Janie, that 25-year-old new dentist coming out, if you don't have a patient that's interested in doing that, then more than likely they're not going to refer it. What we need to look for differently, because I guess, you know what, let me kind of retract here. I think as a newer, younger graduate, Howard, I think a lot of the times we are more potentially timid on the discussions that we have with our patients. If I look at you and you were this young 25-year-old patient, right? I'm a young dentist and I'm looking at somebody that's one of my contemporaries. It may be very hard for me to say to you, if you didn't bring up that I think I have a gummy smile, it may be hard for me to say, hey, does it bother you that excess gum is showing? So what I can tell you, my advice to these individuals is this: give a patient a mirror, put it in front of them, and ask them, what do you see? And if a patient says, well, I see some gum showing here, and I see a long tooth here, and I see a black spot here, then what you're going to be able to do is start a conversation. And that may be one approach that you can have if you're coming out and you don't feel comfortable starting that initial conversation with the patient.
I only like to say, this is Dentistry Uncensored. I don't like to talk about anything everyone agrees on. I always go right for the controversy. Like when we talk about crown lengthening, half don't, half never do it, half can live without it. Another huge controversy, especially on Dental Town, is this oral systemic length. Some people think that periodontal disease and gum disease is causing cardiovascular disease. It's showing up in Alzheimer's plaque, on and on and on. Then other people say, hey, when I get up in the morning and make my coffee, the sun comes up. Me drinking coffee did not make the sun come up. It's a correlation. It's not a cause effect. Where do you sit on that?
Yeah, absolutely. Great question. So I'm going to go back to what my new patient experience is when they walk in the door. Okay. What we always tell our patients is our goal is to get you healthy in the quickest manner possible. And whether they're coming in, Howard, for an aesthetic crown lengthening, as you mentioned before, or they're coming in because their doctor referred them for periodontal disease, or they're coming in for periodontal recession treatment, the way that we're going to approach it is that our goal is to get you healthy in the quickest manner possible. And the way that we explain that we're going to do that, we do that in a handful of ways. The number one way is educating you as a patient. And this is what we'll say to the patient. So before we do any type of art, we call it a tour of your mouth. Before we do the tour of the mouth in your mouth, I'm treating you as a patient right now, Howard, okay? So before we do a tour in your mouth, I'm going to explain to you why we're doing this and the importance of it. And what we'll explain to our patients is we know that there's a very strong relationship. We can't tell you that this will cause this problem, but there's a strong relationship between the mouth and the body. And we'll tell our patients the mouth is the window to the body. And we know that if this isn't healthy, if there's inflammation in the body, then the bacteria that's causing the inflammation or the infection can travel into the bloodstream and be associated. I'm going to tell them again, not causative, but can be associated with heart attacks, strokes, high blood pressure, cancers, Alzheimer's. And men, when you throw out the Turkish study of erectile dysfunction, that's when men really, you're asking about how you get the attention of men, you tweak it to what makes sense to them. And then the second part of that, Howard, is we're going to explain to you, the patient, we're going to say, and did you know that periodontal disease can be contagious, right? And you pause for a second. And when you tell somebody that periodontal disease can be contagious and their spouse is sitting across the way from them, all you have to do is get up and walk out of the room because you're going to start hearing them scream back and forth. Not really, but there's an argument that can ensue.
Well, it's so crazy. If you saw someone every 3 months for an STD, say it was chlamydia, every 3 months you wouldn't see them every 3 months for years and years and years. I was saying, hey, can I see your husband? This is a herd disease. And I think it's insane when you go into a dental office and you're seeing grandma every 3 months for the last 10 years, and she still has bleeding gums, and you've never seen grandpa, when they know that just a mild kiss transfers 80 million bacteria, fungi, microorganisms. And when people say, well, it's not contagious, I want to remind you of something. Dentists, if you say, what causes the cavity, they say Streptococcus mutans. Research today shows that at 4 millimeters deep into the lesion, there is no more Streptococcus mutans. And when they're analyzing decay 4 to 6 millimeters deep, they discover a new species of bacteria every quarter. So just because we think we're so smart because we have an iPhone and we went to the moon, I guarantee you 1,000 years from today, we're going to realize that we were making a lot of decisions without a lot of the data and a lot of the knowledge. Right. And God, look how much smarter, how much more they know now today than they did 30 years ago when I got to school. I don't see how it couldn't be contagious. It blows my mind.
You did say something really interesting a minute ago, though. You said there's controversy about the oral systemic link. we refer to as a periosystemic link, right? Because how many microbes do we have in the mouth that don't necessarily result in what we're discussing here, periodontal disease or bone loss, loss of the periodontium? It's actually the microbes from the way that I believe, the way that I've studied. It's the microbes that are getting within the periodontal sulcus or the pocket. And that's what we find to be traveling around, into the bloodstream, and that they found in the plaques around the heart, for sure. I mean, you've seen the literature, whether you believe that it's causative or associative. I mean, I believe that it's associative, like you mentioned. But like you just said, I mean, what are we doing each and every day? We're trying to educate our patients. So if you can educate them on stuff like you just mentioned, that there is, you're potentially passing saliva back and forth between that one little smooch. We kind of joke about it. You make it fun in your practice. Your patients don't need to come to you and you scare the hell out of them, right? I mean, it's just like telling a kid, if I told my 7-year-old he's got bugs crawling in his mouth, it's going to freak him out. He's going to run the other way. But if I tell him he's got bacteria, he's a 7-year-old. He understands just like the 21-year-old or the 55-year-old in my practice. You need to talk to relate to them, but you also don't want to mean what you're saying. The best advice that I can give to anybody is get your patients to own their disease. Own their disease.
I'm doing everything I can do to get you in trouble. This is a very controversial question. 12% of the dentists work in corporate America, and they have a lot of clinical directors. Many times they're not even dentists, telling them, what they have to do. But a lot of them, if any patient has anything over a 5mm pocket, they have to place an arrestin because there's an insurance code, and corporate's about big money. What do you think of the practice? Would you work in an office where everybody that had a 5 or 6mm pocket or greater had to place an arrestin and bill their insurance for it? What are your thoughts on that?
You were trying to get me in trouble. You're not kidding, huh?
Yeah. And arrestin is the minocycline. And there's another one.
Yeah.
What's the other one besides arrestin? It was a chlorhexidine chip. What was that one called?
Peri chip, yeah. Here's what I can tell you. 4mm pockets and beyond, we know that with blind methods, depending on the literature that you read, that we are missing the debris in a 4mm pocket and beyond anywhere between 36 to, I believe right now, the literature says 47%. On average, it's like 41% of the time. So whether you're putting a chip in there or whether you're flip, chips, whips, whatever you want to call it, right, in the pocket, the problem is if you're not getting out that debris, if you're not getting rid of the irritant, if you're not getting rid of the microbes, what is the medicament going to do in that pocket? And think about it. Listen, as a periodontist, you know this. How many times in our office, sometimes what we'll do is we'll scale a root plane in the pocket before we open it up. Because what happens when we open up that pocket, even if it's a 4 to 5 to 6mm pocket, you open up and this beautiful, shiny piece of dark thing staring at us, right? Because we just burnish that calculus over and over and over again. So I have a hard time understanding that by keeping that potential irritant in the area, how is any type of medicament really going to work?
Again, not to throw my homies under a bridge, but if you're my age, 55 or older, still practicing all the way to 75, a lot of these old doctors, whenever their hygienist does root plane curettage, they write them a script for Pen BK. Because so is that your same thought? Well, so what's your thought on that? What would you think of a dentist? Because I just start naming off names that every time their hygienist does 2 quadrants, they do right side, left side. They scale the right side and the left side, and they scale the right side, give them Pen BK, 500 milligrams, 2 stat, 28 tabs, and then they come back and do the left side. They do it again. What do you think of that antibiotic protocol?
Yeah, listen, fortunately, I don't see that a lot anymore. I see people trying to really get to the root of the problem. I encourage, really, if you're going to do a closed approach, right? If you're going to be doing a closed approach, really understand, how deep can your instrumentation go if you're 6-7 millimeters, okay? So if you're going to be doing a closed approach, you better darn well do it right. And you really need to understand where the pocket is. My thing is, instead of using antibiotics, understand, again, it goes back to understanding your host. Why are you using antibiotics? Are these individuals, Howard, I throw that back to you, these individuals that are prescribing these prescriptions, what are you doing by prescribing the prescriptions? What is the science behind that? What is it, evidence-based? Is that why they're doing it? And that's what I'm going to ask a lot of my clinicians. If they're doing something, whether it's sticking an Arrestin in there, I mean, unfortunately, and I think this is a good point to make at this time, in this juncture in this conversation, going back to having those awkward conversations with your patients when you're not used to having it because you're first coming out, the same thing is, as a specialist, we get alarmed and concerned sometimes about, we don't want to upset the referring doctor, right? So a lot of times we don't have these strong conversations because we're afraid we're going to, for lack of a better word, piss them off, right? You don't want to piss off your referrals. You said we're uncensored, so we're just going to go there. But you can't be afraid, not only say challenge them, but positively challenge them. Understand why somebody's doing something. If they have great science behind it, so be it. But I can tell you in our practice, if somebody challenges me, I'm going to be able to throw a piece of literature right in their lap because I want them to know that the only reason I'm doing it is because it's got the evidence base behind it. And then, as you asked me with the LPRF or the MD, if I can clinically back that up as well and see the positive results, well, hey, winner, winner, chicken dinner. What do we do? It's the art and science of what we do. It's being able to prove it. It's evidence-based, clinically sound results that I want to be able to provide in my practice.
So I know you love the literature, so they probably want to know, what electric toothbrush did you go with?
Let me put a disclosure in. A lot of us that do speak, obviously, we are supported by certain companies. So is that fair enough to say right now?
Sure,
so
absolutely.
I want to absolutely say that. But with that being said, I get involved only with the companies that I want to partner with. There's a lot of people out there, can I digress for 1 second here?
Please.
Okay. So here's what's really interesting. As you train, if those of you may want to get involved with leadership, or you want to get involved with speaking or writing or whatever it is, make sure that you understand that everybody's got their different approaches, right? Because how many speakers have we seen get up on the lectern, get on these main podiums, and I like to say when I show things, it's the good, the bad, and the ugly, Howard. But how many times do we just see the good? And they're really good. And there's no bad, right? So for me, that's to their discredit, because I'm going to tune out very quickly if I see somebody that shows all perfect, all beautiful, right? So we also need to understand that there's a lot of speakers that have been backed by different companies. So you're asking a very apropos question. I love it, because for me as a speaker, as a lecturer, I'm only going to speak about products or support products because I'm using them clinically as well, right? So in our practice, what we use is primarily use the Oral-B products. And that's based off of because of the science that's been provided to us, and that we've studied the literature, the evidence, and the results.
And which Oral-B electric toothbrush, what model?
Right now, they've recently come out. I'm not even sure if you can actually purchase this in the consumer world. I know that they provide them through a lot of the practices, but there's a product out there called the Genius. Have you heard of it?
Well, I'm a genius, so
you are a genius. A genius or a genius.
They
right?
named it after you and me.
Genius or a genius. No, but I like that because, again, going back, Howard, to what we said, you got to have the patients own their disease. The Genius is Bluetooth technology, so there's actually ways to communicate with your dental practice. And that's really cool because I can hold a patient. I don't do this with a lot of patients, but some patients want that interaction. They want that technology. They want to know that you're one step ahead. So if there's a way that I can communicate via Bluetooth technology with my patients, how cool is that? It goes back.
Well, they have the Oral-B Genius 8000, and they have the Oral-B Genius Pro Electric. I like the 8000. It's they sell it at Walmart for $156, but you get the Oral-B Genius for $99.99. Gosh darn, the hour's gone. We went up, but I still had one more question. Can we go into overtime for one more question?
As long as you don't ask my height, my weight, and my age, we're good.
Last and final question, and I'm just I want to talk about what's stressed out. So here's in the field. Here's reality. You're in you're in Kansas, Oklahoma, Arkansas. Grandpa comes in there. He has no pain. He loves his implants, supported to bridge, or is all on 4 or whatever. You're 25 years out of school. He's got 25% bone loss on these things. They got 8mm pockets, and she says, you got to go get treatment. And he's like, I don't have any problems. I don't have any pain. And I can eat a bacon cheeseburger, and I could bite your finger off. And then when she goes, on Dentaltown, it's pretty obvious that there's not even a consensus among periodontists what the protocol is for peri-implantitis. So
Right.
she's kind of like, the patient doesn't know it's there. The periodontist really don't have a consensus or a protocol on peri-implantitis. Should she just tell them to get a water pick and start using a lot of mouthwash, or what's your, here, I just vomited 25 peri-implantitis things at you. Grab one of them and answer it.
No, before I answer it, I mean, I think everything that we've really said today goes back to, the point of understand that we're going to have to be out of our comfort zone. I think I lost you again. You there?
I'm there.
Okay. There are going to be uncomfortable conversations. That's number one. Whether it's with the patient, whether it's with another dentist, whether it's with the referring dentist. That's the one thing we have to realize. What we do, again, they call it practicing for a reason. I don't think there's one right way or one wrong way to do something. Well, maybe there's a wrong way, but not necessarily the right way, right? So I think the number one thing you have to do is you've got to inform your patients. As if you're talking about now, Howard, are you talking about like a general dentist that patient walks into the general dentist practice?
Yeah.
Yeah. And so the general dentist is the one that's graduated within the past couple of years?
Right.
Right. Okay. So the number one thing is that general dentist may not understand, just like you said, there's no consensus for surgeons, for periodontists or oral surgeons, whoever it is, on how to treat peri-implantitis. You don't have to vomit out of your mouth the treatment options, right? Like so you just said, okay? But what you do have to do, we are held morally, legally, and ethically up to a certain standard. And that is to inform our patients about disease, right? What is one of the number one things that we see in dentistry that unfortunately goes into the litigious world is because of either misdiagnosis or no diagnosis. Is that an accurate statement?
Yes.
So if you, Howard,
and failure to refer.
Exactly. Yes. Right. But that also goes because of misdiagnosis or no diagnosis, correct?
Right.
So you as that new dentist out, you don't necessarily have to say this is how they're going to treat it, but you have to, in my best recommendation, for whatever that's worth today for the last hour that we've been with, you have to inform the patient that there is disease present. You have to take the proper documentation radiographically and show them what's going on. Because every patient is going to have a different level of understanding. And you may think they understood, right? But how many of those patients look at you with blank stares and they just don't say anything? And that's the scariest patient to me, is when they don't ask a question. So you have to make sure that you inform, that they acknowledge that you've informed it. And what's the most important thing? If it's not written, it never happened. So you make sure you document that conversation as well. That is so, so, so important. And you know what? There's going to be a lot of patients that you're not going to be able to win the fight in this battle. That 65-year-old patient that's had those implants for 25 years and they can still eat bacon, they may not ever damn well do anything. Correct? And you and I both know this, but it is up to us to at least inform them. That's my take on it.
Yeah, and also young doctors, don't be judgmental. One of the things I don't like is when these young doctors, they want to dismiss a patient because they're not doing it right, or they're smoking or whatever. Look, I mean, I can name you 10 ladies that come to my office in wheelchairs with oxygen tanks in their nose, and they're smoking outside
Absolutely.
my front door. And I love them to death. I give them a hug. I kiss them on the cheek. I mean, that 80-year-old lady shouldn't be smoking next to an oxygen canner, but she ain't never going to change her mind. And she needs a doctor, and she needs a doctor who's not judgmental. Everybody
Right.
needs a doctor. So, humans are crazy. In fact, the older I get, the more I realize I'm probably the only normal person on earth. I think we can all agree on that. But hey, Jennifer, seriously, God, I hope someday we get an online CE course or an article from you. I think you're amazing. Your resume is just to die for. You've done so much. I mean, gosh, top 10 young educators, America, Seattle Study Club. You're already in the International College of Dentists and American College of Dentists. You are all that and 2 bags of chips. I want to thank you so much for coming on my show today and talking to my homies. It was an absolute honor to podcast interview you.
Well, Howard, this has been a true honor, a privilege, and I'm beyond humbled to have had this experience. I really am. Thank you so much.
Oh, thank you. And thank you, Ryan.